It is the guidelines. And then, in the role in intravascular imaging, we know the acute coronary syndrome, almost there was a thrombosis. So thrombus detections we can see by intravascular imaging, and OCT is the best for evaluating is there any thrombus or not in the publication or non-publication, but non-publication maybe there is no thrombus. And sometimes we have to identify the plaque. This is the risk to outcome or not. So, like infus, they define the plaque burden more than 60% is below to risk. Or a lipid risk plaques are more than 400, it is below to risk. What is meaning the below to risk? Maybe at the next time the patient will get acute coronary syndrome again. And we have two modalities to evaluate intravascular imaging by infus or by OCT. But to identify the culprit or non-culprit in the ACS, maybe based on this table, the choice we do with the OCT modality, because we can identify it, the plaque rupture, plaque erosions, or maybe the thrombus or spontaneous dissection. So how to identify the vulnerable plaque? The vulnerable plaque meaning is thin cup, fibroadenoma, and there is a large lipid cover covered by thin fibrous cup. This is prototype to rupture vulnerable plaque. So like cup fibroadenoma, we can see is there any macrophage in the fibrous cup, and sometimes there's erosion and thrombus in intravascular imaging. From the image, from the OCT, we can identify the lesions. This is the precursor lesion to thrombosis. The first, like previous slide, we have to identify thin cup fibroadenoma with a large lipid score, and is there any large invited cavity after lipid protocol has been expelled to the lumen? And then the eccentric plaque, predominantly fibrous, plaque with superficial irregularities, this plaque erosions, and maybe sometimes in there there is thrombus attached in the edema. And then the last one from the OCT, the precursor lesion of the coronary thrombosis is eccentric nodule calcification, but this is by thin rim of tissue and eruptive calcified nodule. So, is there any difference morphology between stemma or non-stemma by intravascular imaging? From this study, we can see in stemma patient, the intravascular imaging by OCT, the fibrous cup look like more thin, plus more than 90 micron, and the more thrombus and more red thrombus in stem. It is a specific lesion in stem. In stem, the aperture of rupture plaque is open wedge against the flow of the direction of the flow of the coronary. But in the non-stem, the aperture is open along the direction of the coronary flow. And I cannot define how it can like this, but the aperture is open along the direction of the coronary in the non-stem. And then, how with non-culprit lesions? By intravascular imaging, STEMI or NSTE. We know the complete revascularization of non-culprit disease in the patient with STEMI now has a class 1 recommendation. However, the complete revascularization in STEMI would be feasible option considering the excess of recurrent event, especially if non-complete lesion would harbor high-risk features, which is similar with the STEMI. This is an interesting study because the non-complete lesions in STEMI and non-STEMI, and they evaluate with the FFR. If the FFR is normal, it is more than 0.8, and then they identify that this belong to high-risk plaque or not high-risk plaque. How about non-STEMI? In non-STEMI, in non-complete lesion in non-STEMI, less frequent had a lipid plaque, and the lipid length was shorter. And non-STEMI, less frequent had lipid arcs more than 90 degrees. And non-STEMI has plaque rupture, which is the same with the STEMI. No evidence in prevalence of high risk plaque between STEMI and non-STEMI. The high-risk plaque in non-complete lesion by intravascular imaging, especially by OCT, at least we have to meet 2 or from the 3 characters. If the lipid are more than 90 degrees, and there is a thin fibrous scar, and presence of thrombus or fracture plaque. So after the follow-up 2 years, among the high-risk plaque features, plaque rupture is significantly associated with adverse outcome in both STEMI and STEMI. But in STEMI, the accumulative incident during 2 hours around 20% versus in STEMI only 11%. So equal presence of high-risk plaque integration cohort, the higher incident MIS and non-fatal MI, particularly in patients with STEMI, and especially patients with STEMI and high-risk plaque were very high risk for recurrent event with 2 years incident MIS around 20%. So the recomposition, the STEMI approximately 40%, and imaging reconstruction for coronary thrombosis is dental fibroadenoma, eccentric plaque, or eruptive vascular plaque, and maybe it's need to additional research, especially to complete revascularization in STEMI as well as on treatment of vulnerable plaque or high-risk plaque after infarct. Thank you.
Thank you, Dr. Nahar. Please sit in this audience. So we have 3 Dr. Go, can you add some comment to any speaker?
Yes, I have a question for Dr. Mentioned that from the registry that there is a difference between before COVID and after COVID in the profile of patients with ACS and also the treatment strategies. So, would you like us to get on why is that so? Why has COVID changed the profile and the treatment strategies?
Yeah, thank you. So there's a difference between before COVID and after COVID. Probably we don't have any explanation, specific explanation on that, but we assume that there's a long-term effect from the COVID itself, which is we know that COVID is also a cardiovascular problem of cardiovascular disease involved in COVID-19. That's why we we have different demographic features or demographic features in the after COVID era. So that's why it's also but it also affect the strategy that the strategy, especially infrastructure strategy in non-STEM, which are more and more invasive strategy performed after the COVID era for the very high risk patients.
So I think that because of the screening of the COVID may delay for the early intervention. Right. Okay. Please, Anderson.
I have a few questions. So based on you have a data history, I mean, I saw that one of the cause of mortality is respiratory failure. It's the second highest cause of mortality. So do you cover the data during the COVID time, or do you like just only pre and post COVID? The data came from.
Yeah, the data comes from only, we don't have a specific data on that, what caused that, but that's only after and before and after COVID. So we don't have any specific data on what caused respiratory failure.
Another question is the registry show most of the patient, I mean, majority is quite high risk group. Is there any reason why they present? Is it very little presentation, or the disease when you found it very advanced, or is there any reason to figure it out? Because when I look at the profiling, majority of the patients are pretty high risk group. Plus, huge number like really bad disease.
So yeah, we have a mismatch actually in the mortality, especially in very high risk group. So I can see that there's even in early invasive approach in very high risk group is associated with higher in hospital mortality. So I think what we can see that there's a crucial risk-benefit assessment in this kind of patient, especially when patient with very high risk, including acidosis, shock, or maybe motor organ failure, to make it worse with early intervention. That's maybe the suggestion of to see the risk-benefit assessment from the early intervention. That's we don't actually don't know why this is happening, but that's the clear situation that we have from the registry.
And thank you. I got one question for Dr. Now. Exam patient, imaging to rectify the high risk plaque in the NSTE group. I mean, in your practice, I mean, for example, you found a patient with multivessel disease, especially with the NSTE. So sometimes we may not know which is a culprit. LAD may have 70-80%, RCA may have another 70-80%. In this type of pandemic context, do you straight away offer revascularization strategy based on the anatomy, or sometimes do you want to, I mean, in your practice, do you still want to find out the anatomy by the imaging? Because based on the CT data, some of the anatomy, the articulation came from the minor disease. This is what the CT data show.
In my daily practice, we use the travel imaging good translations. But if we can find the interpretation based on ECG, based on angiography, maybe didn't use the
Thank you. Another question is, sometimes angiographically not significant, patient came in with the NSTE, angiographically pretty clear, but some of the area is suspicious. So you did the imaging, then you find out that there are the plaque or recent rupture, which only can see by OCT or IRIS. In this clinical context, in your practice, you use more on the stent strategy or more on the DCB strategy in your daily practice?
We find we miss the further part in the amicus geography, medical way. But if we sure that is the
Thank you.
Continuing to Dr. Ahad, I'm interested with the SMI. We know that the SMI is correlated with the multifactorial system, and then sometimes the indications keep it. I mean, the patient usually refers for the CABG, keep for the vascularization, and maybe. What is the role of the IFOS and also the OCT to know that we have to just open the vulnerable blood or just to do some complete vascularization to the patient with multifactorial disease?
Yes, especially in studying with multifactorial disease, we may have to do with full breakfast. And then if we meet another lesions, we have to wait. Is this the ischemic or not? Like if you study, they reported that the multifactorial disease with FFR and functional is normal, but from OCT, they reported that it belonged to vulnerable plaque or high-risk fracture. 2 years later, the ECG miss around 20%. So, yeah, maybe we are clinical activities here. If we should be this the vulnerable plaque or high-risk plaque, maybe we have to treat it. But like my last slide, it seems needed to
Thank you for the panelists and the speakers. And I will give the summary of our discussion. Dr. Indah mentioned about the biomarker as tool to roll in and as risk certification. Dr. Ahad highlighted about the characteristic outcome and risk certification of Indonesian population, especially patients with non-STE ACS. Dr. Yusuf explained about the early invasive strategy benefit compared with delay invasive strategy, and the last speaker, Dr. Ahad, highlighted about the need to confirm the vulnerable plaque, especially with invasive imaging, to better understanding and treat our patient. Now I close the session. Thank you for all the speakers and all the panelists. Assalamualaikum warahmatullahi wabarakatuh.